And let me tell you what I came to know Dr. Green is that I was invited to be on a particular grant with Dr. Pamela Foster from University of Alabama, the biggest school, Tuscaloosa, University of Alabama, Tuscaloosa on lupus. Dr. Sneed says that Jonathan said, I'm a social gerontologist interested in how the social environment impacts adult development and aging and diverse populations. I have expertise in biopsychological, psychosocial models of health, community-engaged research, and chronic diseases. My work engages community and institutional stakeholders to identify and improve upon factors that contribute to inequities in health and well-being among mid and late life adults. Education, Dr. Sneed received her bachelor's degree in molecular biology from Princeton University. That's where our advisory council co-chairperson, that's where he did his stuff, got his stuff, Princeton University. And then she have a master's in public health and epidemiology, which is what I'm going to reference when I give my portion, from Columbia University. And she has a Ph.D. in social health and psychology from Carnegie Mellon University. She's also a postdoc fellow on social gerontology from the University of Pittsburgh. I don't know. You look like you're 25 years old. God bless you. So you have all the cover the gamut. So God has blessed you. This is beautiful. Now, so Dr. Sneed, the floor is yours, and help us to understand lupus.
Absolutely. Thank you so much for inviting me. I'm pleased to be here today on behalf of a team of lupus researchers and colleagues that have been doing a lot of work in partnership with the Office of Minority Health to reduce inequities in lupus. In particular, we see a lot of disparities in lupus, such that we see higher rates of lupus in Black populations than we do in white populations. And so what I want to do is kind of tell you a little bit about lupus for those of you who haven't heard of it, and kind of tell you some of the things that cause lupus, and kind of think about some of the issues that a lot of Black women in particular face as they're trying to navigate a chronic health condition like this. So I do have slides that I will put up, but I'll talk to you as well. But I did bring some slides just so you can follow along. And so since Dr. Hodge told me this was, very much focused on ethics, I really wanted to talk to you in particular about some of the ethical concerns that Black women express when they're talking about lupus, both in the care that they receive when they're in the clinic setting, and also when they're approached to engage in research. So I'm primarily a researcher, and so I'm going to talk to you a lot about some of the research that I've done with my colleagues at Northwestern in Chicago, and also at Harvard in Boston. So I want to start off by just telling you what lupus is, and then I want to move on to talk about some of the racial disparities we see in terms of who gets lupus. Then I'm going to move on and talk about a research study that our team conducted specifically to understand some of the ethical concerns that Black women have with respect to the clinical care that they receive while having lupus, and also their desires to participate in research. And then finally, I want to offer some potential solutions for ways in which we can actually think about improving outcomes for Black women who have lupus. So first of all, what is lupus? So lupus is an autoimmune condition. So one of the things that we're fortunate to have is, part of our body's defenses is that when there's some sort of foreign agent in the environment, our bodies mount an immune response. So you can think about something like, encountering the flu, or encountering some kind of bacteria, or even more recently talking about the ways in which we encounter something like COVID-19. Our bodies respond, and our immune systems attack what it perceives as a foreign invader. So, we have cells that actually come in and mount this immune response to attack the foreign invader, or the body temperature may raise in an effort to kill, some virus that might come into the body. So what happens with lupus is that our immune systems go into overdrive. And what happens is the body looks at normal, healthy cells and tissues and somehow misinterprets those as foreign bodies. And so the immune system actually attacks the cells and the tissues of the body. And so, again, we're talking about healthy cells and healthy tissues. And so, as a result, what happens is we get a lot of inflammation in the body. And as a result, a number of different organs can be damaged. And so when you're talking about lupus, no two cases are just alike because it really depends on what aspects of the body get attacked by the immune system. So you'll see people who have lupus and it attacks their joints. You'll see people with lupus who get skin rashes. What's common is there's what they call a butterfly rash that goes right across the cheeks. That's sort of a hallmark symptom of having lupus. You'll see women who, for example, have their lupus attack their brain. And so as a result, they may have sort of neuropsychological problems. Lupus can attack the lungs. It's common to see that people with lupus have kidney damage and heart damage. And so we don't know exactly what lupus is caused by. There's some suggestion that there are genetic factors that contribute to it. And we also know the social environment can contribute to it as well. So when people are under stress, their lupus tends to sort of flare up. But we don't know exactly what causes it. And unlike a lot of the sort of the foreign bodies I talked about earlier that are infectious, lupus is not something that's contagious. You're not going to catch it from somebody else, but it is something that does tend to run in families. So lupus is also a condition that's characterized by a cycle of flares and remission. So people go back and forth between having more active disease, which is what we call flares, and then having more stable disease, which is what we call remission. And so there isn't a cure for lupus, but really the goal is to help manage the case such that you have more remission and fewer flares. And so there are a lot of different warning signs of when a person is having flares. So you'll see things like swelling in the joints, weakness and pain, fever, fatigue, hair loss. These are all things that happen, and women typically go through cycles of this. So, sometimes if the immune system is suppressed appropriately with medications, you'll see remission. And when that suppression is not working as well, you're going to get the flares and you're going to get more of these signs and symptoms. So who gets lupus? So lupus is something that anybody can get. And we estimate that anywhere from 160,000 to 322,000 people in the United States are actually living with lupus. But there are some people who are at greater risk. We noticed that 90% of people who get lupus are women, and women usually get it when they're at reproductive ages. So between the ages of 15 to 44, which suggests that there may be some kind of hormonal component, the fact that people are getting it at reproductive ages. We also know that non-whites are more likely to get lupus than whites. So in particular, people who are of African ancestry, those who are Hispanic, Asian, or Native American are more likely to get disease than white women. We also know that family history plays a role. People who have lupus tend to have family members who also have lupus or some other kind of autoimmune disease. Probably one of the most famous Black women who has lupus would be Toni Braxton, the R&B singer, who's in this photo here in the middle. And actually within her family, there's a fair amount of history of lupus. So her brother, who's the second from the right in this photo, has a form of lupus. And she's also mentioned that she had an uncle who died from complications related to lupus as well. So again, this is a disease that very much impacts families. And so when we talk about Black women and lupus in particular, lupus is 3 times more common in Black women than in white women. And experts estimate that 1 in 250 Black women will at some point in their lifetime get lupus. And when Black women get lupus, they get it at much younger ages, and they tend to have more severe disease. So Black women, for example, are more likely to have kidney damage. than white women. They tend to have more flares and more severe flares compared to white women as well. So we're talking about disparities. We can talk about racial disparities in who gets lupus, but we also have very much racial disparities in who actually participates in lupus research. And so this is really important because lupus experts really say that the best way to reduce the burden of lupus is for researchers to understand what causes lupus and for researchers to develop effective treatments to counteract the impact of lupus. So if Black women aren't participating in research, that means that treatments for Black women are not really being well studied, which has long-term implications for whether or not Black women can have more stable disease rather than active disease. So we can think about the burden of lupus in Black communities. 43% of all lupus cases in the United States are among Black people, 43%. But then when we talk about participation in research, only 14% of people who participate in lupus research are Black people. So that's a major disparity. We have more disease and we participate in less research, which means the odds of being able to find better treatments for us go way down. And so this is really important. And those of us who do this work really have been trying to think about what is it that we can do to increase the participation of Black women in lupus research. And so in thinking about some of the ethical issues associated with representation of Black women with lupus in research, we really think about a few things. One, not having Black women in research really violates the principles of distributive justice. And those of us who do research on people, it's really important for us to think about the principle that the benefits and burdens of research should not just be constrained to one particular group or one population. And so when we talk about the burdens of research, traditionally, we often saw that vulnerable communities were invited to participate in research because they were readily available, even if that research had safety risks. So for example, people who were in prison or people who were homeless were often invited to participate in research because they were available, even though that research didn't have any direct benefit to them. At the same time, in addition to talking about burden, we can also talk about benefit. So the benefits of research should not go to just one population. And so what happens is when we have Black women not participating in research, they're not getting the benefits. All of the new treatments that come out are primarily going to the white women who participate in research rather than the Black women. And so that's really an issue when we're talking about the principle of distributive justice. The other thing that we know about the treatments related to lupus is that sometimes we see differences in the way in which certain groups respond to treatments. So there's some treatments that are more effective in some racial groups than others. Some racial groups have been reported to have more side effects from treatments than others. And so as a result, clinicians sort of face a big challenge in recommending new treatments if those treatments have not been tested on a specific group. So what does that mean for Black women? That means that if there's a new treatment and Black women are participating in research, they're not getting access to these new interventions that may actually be beneficial. And so as a result, what we're seeing is that we're just increasing the racial disparities between Black women and white women when we talk about lupus. And so our research team really wanted to try and understand what the ethical concerns of Black women are, both when they are seeking clinical care and also when they're invited to participate in research. And so we said, let's ask Black women, what's going on when you go and see doctors? What makes you not want to participate in lupus research? And so to answer our questions, we invited 31 women to participate in focus groups. The focus groups were about an hour and a half. We did 2 groups in Boston and 2 groups in Chicago. And the way the study was set up, a large portion of the women who participated were Black women themselves who had lupus, And then we also invited their caregivers to participate. So this is often friends and family members who may help them take medications, or they're the people who drive them to and from doctor's appointments, or who provide them with support when they may have gotten discharged from the hospital. In terms of recruiting our participants, we relied heavily on lupus support groups. The researchers that I work with also are rheumatologists who see lupus patients in their clinics every day. And so we recruited those women as well. And it was really important for us to have focus group moderators who were Black women as well. So we wanted our participants to see women who looked like them and to be able to have frank conversations about things that might be important to them, that they might be less comfortable with in mixed audiences. We recorded our focus groups and transcribed the recordings that we had. And so what I want to spend the rest of the time doing is kind of telling you a little bit about what the women told us. So again, we had 31 women who participated, 31 people rather. The average age was about 54, but they range in age from 29 to 75. 90% of the people who participated were female. We had some of the caregivers that we invited to participate who were male. A fair number of the participants had college degrees, 65%, and over half of them were currently employed. And so when we think about some of the things that the women told us, we asked them, first of all, what sorts of things impact the ways in which you think about clinical care. When you're coming to the hospital, when you're coming to a clinical facility, what are you thinking about when you seek care? And so women told us a few things. One thing that they told us is that when they seek care, they're often thinking about ethical atrocities of the past. They're often thinking about the fact that historically, Black people have not been treated well when they seek care. And so they had a lot of concerns about racism when they go into clinical spaces. And as a result, that caused them to delay seeking care unless they really had to. So one participant said, a lot of minorities, especially Black families, we don't go to the hospital. We wait until the very last minute. So when we do go to the hospital, we die. Don't go to the hospital, they say. They kill you. They're killing you. I think we're not educating ourselves to learn more about our symptoms when we go to the hospital because we're afraid to go to the hospital. Another participant talked to us quite a bit about the history of racial bias in pain management. And there have been a number of studies showing that clinicians have a lot of biases in terms of how they think about how Black people can tolerate pain. So they've done studies with medical residents and, they've endorsed statements like Black people can tolerate more pain than white people. Or if we look at data on who gets narcotics when they report having pain, Black patients are less likely to get narcotics than white patients when they seek care related to pain. And so our participants were aware of this. And they really talked about how that impacted the ways in which they seek care. And one participant said, sometimes when you have an African-American woman like myself come in and complain of pain, it's not always taken to the level of severity if my Caucasian counterpart came in and complained of pain. They don't make that diagnosis as quick. That's scientifically proven. Now, keep in mind when we're talking about lupus, one thing I mentioned is that joint pain is something that's really common. So pain management is a very important part of how you manage a disease like lupus. So having racial bias in pain management is really problematic when you're talking about a chronic condition in which Black women are more likely to get it than other groups of women. So in addition just to sort of thinking about clinical care, the women also told us that past ethical atrocities impacted the extent to which they were willing to participate in research as well. So one thing that a number of the women referenced were the Tuskegee syphilis studies. And one participant said, there's a deep mistrust with the African-American community. First thing a lot of us think of is the Tuskegee experiment. So there's a deep distrust between the medical community and the African-American community. And that's definitely a barrier. Even if you are trusting and see the benefits, it still lingers in your thought process. Another woman said, we have had so much racism. We're thinking of all the things that have happened to us throughout the years. We're going to say, oh no, you all want to do all that disease stuff and testing. No, we know what our ancestors went through. So one thing that I do want to point out as well is in addition to sort of thinking about genetic factors that might play a role in who gets lupus, the other thing that really plays an important role is stress. And so, you know, when people feel more stressed, they're more likely to have disease flares, they're going to have more active disease. It's going to be more difficult to actually suppress the immune response. And so when we think about something about like having perceived racism and perceived feelings of discrimination, that's a stressor, you know, so that's just going to exacerbate the experiences that Black women have, women who already are at greater risk of having this disease, but also experiencing this excess stress contributes to how active the disease may be. So another thing that we were interested in is whether participants thought that Black patients with lupus are treated differently when they participate in research. And people told us, yes, they did think as though they were treated differently when they did research. One participant talked to us about her participation in a research project where she felt as though Black and white patients were being distinguished in ways that she didn't quite understand. She said, I kept saying, I thought this was anonymous. It's not anonymous because I notice every time a person of color comes in there, they go and mark that paper a certain way. So don't tell me this is anonymous. If you're differentiating the Blacks and the whites, just tell me that. I'm still going to do it, but be honest with me. Don't say, oh no, it's anonymous. No, it isn't. You're putting a number down there every time you give out one of these things to somebody of color. And I saw the whole thing go down. I said, this is not right. Not right. So again, this idea that you're being treated differently when you're actively trying to do something good was a really important concern for the women in our focus groups. The other thing that women mentioned to us is they had a lot of concerns about racism in thinking about who is or is not eligible to participate in studies. So most of the research studies we do, we have a long list of exclusion and inclusion criteria in terms of how old you have to be, how long you have to have had the disease, whether your disease is more stable or more active. And we don't necessarily share those criteria with people, but if they don't meet them, they get excluded. And so participants had a lot of ethical concerns about that. One woman said, if you all are doing a clinical trial and say the researcher calls me and asks me, do I have any other health issues besides lupus? And I say to him, I have menopause. They say, oh, well, I'm sorry, you can't do it. Is that discrimination or is that because of the research? I think this is a really important observation because it sort of reflects the fact that researchers are being ambiguous about what's actually happening in the research space. And as a result, when faced with sort of this ambiguous situation, the potential participants are interpreting it as perhaps something that might be racist. And so that a lot of concern was expressed about why is it that I'm not eligible for studies? Why are not people not communicating with me about why I am or am not eligible for studies? You know, and I think so those of us who do this work have more of a responsibility to talk to people more about what's going on in the research we're asking them to participate in. The other thing that women told us is that they were really skeptical if people said that they were purposely going out trying to find Black participants to participate in research. That was very suspicious to them. One participant said, a lot of times when you hear that statement, we're looking for Black people, our antennas go up. Is this racist or something like that? Another participant said, it's not who's saying it, it's just how you say it, period. It could be if you're a Black lady and you're saying, I want you for this research because you're a Black woman, I'm still going to be like, why do you want me for the research? So again, not really explaining what's going on and leaving an ambiguous situation really makes people uncomfortable when you're asking them to participate in something. Another thing that the women talked to us about is the idea of being randomly assigned to participate in research trials. So typically if we're testing a new trial, testing a new drug rather, We have a group of people, and half of them are randomly assigned to get the new drug, and the other half are randomly assigned to get a sugar pill or to be in the control group. So they're given something that looks just like the real drug, but it doesn't have the same effects. And that's the way that we determine if the treatment's actually effective. Our participants really question whether or not random assignment was ethical, especially in the context of having a chronic health condition like lupus, which is really complex. So some of the women told us that they were really afraid to get the active treatment. They were afraid to get the new drug because they were already on a lot of medications. One participant said, "I'm always afraid to participate because of the drug interactions. If you don't know whether you're going to get the placebo's fine, but if it's one of the drugs, it may interact negatively with some of the medicines because I take a lot of medications." Another participant said, "It all depends if there's a medication involved, because I'm telling you, I got 17 in the morning, 12, and then 8. They'd have to be able to work with those meds. If it worked with those, then I could fly with you a little bit." So again, thinking about, is it ethical in the ways in which we think about assigning active treatment when we already have people who take a number of different medications. And this polypharmacy is actually really common with lupus, because you're talking about a condition in which people have a lot of different problems. So they may have kidney problems, they may have heart problems, they may have neurological problems, and each of those may require them to take a different medication in addition to just the sort of the general medications that you take to control the immune system. So it's not uncommon for women with lupus to take a lot of medications. And what does that mean when you're asking them to add on another medication that you hope might be beneficial? On the other side of things, there were some women who told us that they actually didn't feel comfortable being in the control group. They expressed that they would be disappointed if they went through the trouble of participating in a research study and they got a placebo. So one participant said, "If I finally in my head say, I'll go ahead and give it a shot, I would be teed off if I was in there and I stayed there 6 months in your little study or trial thing, and I was getting the placebo for 6 months." Another participant said, "Yes, I would participate in a study. I might feel a little sad though if I found out I was the one that got the placebo." Another issue that people really raised with us is the idea of who gives consent and what it means to provide informed consent. So those of us who are involved in clinical care and in research, we often give patients 10-page documents that tell them what's going to happen. So that document might include a description of the research or whatever clinical treatment they're getting. It talks about risks and benefits and alternatives and privacy, and it lets you know that you can quit the research project or the treatment if you want to. And these are all important things. But participants really told us this wasn't enough. They weren't being informed enough by just getting this 10-page document that talked about consent. So one thing that people told us is that consent really is not just an individual level thing, because they're not making decisions about their treatment alone. They told us that the opinions of their family members very much mattered, and they wanted their family members in on the consent process. One participant said, "I'm very concerned about their feelings because they are the ones that help me when I'm not well. That decision does impact my family because they're not around the corner and they're not up the street. So I do have to take that into consideration." And so one thing that they criticized research for is the fact that they're not necessarily including family members and having those important conversations about whether to participate in treatment or to get certain types of clinical care. They also pointed out that their family members sometimes have negative opinions of research and of certain types of clinical care conditions. So it was really important for clinicians and researchers to talk to their family members. One person said, "I'd like to be a part of clinical trials, but the family's pretty adamant to say no. They don't know if this treatment's going to work and if it's going to make my condition worse. I have had times of really bad flares or hospitalizations and things like that, and they just don't want to see that again." Participants actually also told us that it was important to talk to their family members because sometimes their family members can encourage them to participate, even if they themselves were nervous about participation. So one person said to us, my sister, she gets a study and she'll tell me about it. As soon as she hears something, she'll tell me, why don't you go and do this? My sister will be the one to say, I'll go with you. She'll take that fear off me. She'll say, I'll go with you. And that makes it much easier. So by not really including the entire family in the process, we're potentially missing out on the participation of these Black women who do have lupus. And so when we're sort of thinking about what it means to provide informed consent, for them, it wasn't just about this individual informed consent, but really including all the people that were important to them. The other thing that people told us is that their personal doctors also matter to them, and they want their personal doctors to be included on any treatment decisions that they make and on any research studies that they choose to participate in. So usually, a person with lupus, I've mentioned, lupus can impact lots of different organs. So your typical woman who has lupus has a primary care physician who's sort of managing her overall health. She has a rheumatologist who is focused on lupus and the impact of her lupus. And then depending on which organs are damaged, she may have other specialists. So she has a kidney doctor potentially. She has a neurologist. She has a cardiologist. And so when it comes to navigating decisions about treatment and research participation, they told us they want those people in the room. They want to make sure that those people understand what's going on because those are the people that they trust and who they have relationships with. So one participant, made a point of saying that they want to be able to consult their physicians about any medications that they take. Another participant talked about the fact that she had multiple doctors. And so anything that she wanted to do, if her kidney doctor wants her to do something, she has to check with her rheumatologist and vice versa. So it's important to have collaborative conversations with both social network members like friends and family, but also to include physicians that they trust in the process as well. And then the other thing that women told us is that the institution itself matters. They don't want to go to doctors who do nothing but research who don't care about their communities. So they don't want to interact with what we call helicopter researchers. So we think about a helicopter during some kind of disaster. The helicopter flies overhead and it may drop supplies to help mitigate the effects of the disaster, and then it flies back out. That's not the kind of care that they want. They don't want doctors who come in, tell them to participate in some sort of research, and then they never see them again. They want to go to institutions that are in the community, that are actually interested and care about the community. So one thing participants said to us is this a place in the community outside of this research? Are they visible? Are they present? Do we know of them in another capacity other than wanting to come and do a clinical study or a clinical trial? So in addition to sort of having the support of their friends and family and their physicians, they also want to know that they're going to an institution, to a clinical space that actually has some investment in the community where they live. Another thing women told us is that when they're talking about giving consent, that it's not enough just to give them a 10-page document to read that has a lot of jargon in it. They want to have multiple ways of kind of understanding the consent process. So they said things like, show us videos, give us something we can watch. We want to do more than just read. We want to watch and we want to be able to talk about what's going to happen, what's going to be done, what procedures are we going to participate in. So, they talked about the fact that they don't ever get anything like that. And that will be really beneficial in terms of helping them to make decisions about whether or not to participate in new treatments. And then another thing women told us is that giving consent is not just this one-time thing. It's really an ongoing process. And they wanted to be able to have conversations throughout the process. If you're asking me, for example, to participate and to take some new drug, I want you to talk to me all through the process. Don't just sign me up for something and send me home. And so participants talk to us a lot about the importance of having ongoing communication if they participate in research. They want to be able to have lots of conversations and talk to other people as well so that they don't feel isolated while they're participating. So I want to end just sort of taking all that information and kind of putting it together to really think about, given what we know about racial disparities in lupus and the concerns that women have about how they get care and whether they participate in research, what can we actually do about this? I think the first thing that's really important, and the women told us that they want us to acknowledge the fact that bad things have happened. They've happened in the past and they're happening currently. You know, our country has a history of not treating Black women and Black people well when it comes to healthcare and being very upfront about that. You know, they recognize the fact that, you know, there have been efforts to do better, but still there are these historical things that have happened and they're shaping the experiences that people have even today. The other thing that they really told us is that it's important to communicate better. You know, so if you're going to exclude people from certain treatments, tell them why. If you want people to participate in research and to get certain kinds of treatments, tell them why. Third, they really, again, wanted you to recognize the fact that they don't live in isolation. They have people who care about them. They have friends and family members and physicians that they trust, and they want them to be included in any sort of clinical decisions that they make. And then finally, when we're talking about the institutions that are serving Black women with lupus, they really thought it was important that those institutions have a vested interest in them and in the communities where those institutions are located. And so they stressed to us the importance of really actually partnering with those who work every day in the community and having real authentic partnerships within communities in order to build trust among them. And so I'll end there, but I just want to acknowledge my colleagues at Northwestern and at Harvard who helped us to run this project, and also the Office of Minority Health that funds a lot of our work. And with that, I'll take any questions you all have.
Thank you so much, Rodlescia. What a beautifully, wonderfully hard way to end this week of conversations. I would like to actually say a couple of things, because the way you spelled it out so nicely, incredibly nicely, Emily. You made it such that anyone could understand. One wonders why informed consent are always not spelled out the way you just spelled everything out, and including one of my Dixon and I, Dr. Christian and I, literally closest friend who grew up with us from almost out of the crib. He had a heart situation, had to replace a valve, and he had informed consent, and he had they gave him two. They asked him if he wants to. They showed him a video. They're talking about the modalities, right? They showed him a video, so he could have a clear understanding what happened. And they gave him two options. They said, "Would you like to see an animated version, or do you want to see the real version?" He said, "Man, I'm not weak. I can handle this. I just want show me the real thing." When he saw the real version of cutting open the chest with a saw and the heart pumping and what they actually had to do, he almost passed out. So the informed consent, I completely, totally agree that there needs to be different ways of seeing and understanding and comprehending and offering the informed consent so that people can understand, as well as the person who said that Jonathan, can you come on, please? As well as the people who said to wait to the for the last minute and before they get involved, and in that waiting, by that time the people are dying. You know, they're waiting for the last minute. So now here's the question. This is my distress. All through this week, but none more poignant than this one, because of the ethics and the clinical trials portion that you brought up, as well as the All of Us program that many of us are part of. With the insane amount of comorbidities that Black and brown people, especially in this particular conversation, Black women face, such that those numbers I just gave, I think it's like 17. Is that 17 medications, pills? And
Mhm.
well, okay.
Mhm.
So now, you were saying, well, not just comorbidities, it's like quintuplet comorbidities
Mhm.
and a
Mhm.
whole lot of stuff that will give um um maybe false indicators about how this person will be treated or how this treatment is working. And so
Mhm.
that person may not be the best possible person to utilize in a clinical
Mhm.
trial. But this person is in a bad situation. And because
Mhm.
Black and brown people lead in every conceivable excess death category,
Mhm.
there's like 9 or 10 of them right now.
Mhm.
Therefore, the likelihood of finding for clinical trials Black and brown women who
Mhm.
are not, I don't know if what the word
Mhm.
is, a comorbidity,
Mhm.
comorbidity.
Mhm.
The likelihood of finding that person is highly unlikely or very
Mhm.
difficult to find. And that means whereas we need about 50% of those in the clinical trials to be a Black or brown, you're only getting between 5 and 10%.
Mhm.
So
Mhm.
now it's really scary. What I
Mhm.
suggested in my presentation on to this conversation, what I said, what I made to the group that what Alicia and I served on, is that we need to shift our ethics of the ethics that we utilize to get to the women and the population that we're trying to serve. The ethics that we typically utilize um, in public health is called, here's a big term for us, utilitarian ethics. That means the greatest good for the greatest number of people. Just make it
Mhm.
straightforward. The greatest good for the greatest number of people. But we're talking about minority populations.
Mhm.
So they're already on the bottom. They're not the majority. So the greatest good will be to the benefit of not the least the lost of the left out, but it'll be to the benefit of those particularly white women.
Mhm.
Um, so now we have additional challenges. So what I suggested in my presentation is that we reshape our focus, and what we do is we develop an empathy care ethics
Mhm.
that and attach the work we do to empathy and care. What this does is it creates a greater focus not on the number of people, but on the particular person.
Mhm.
And therefore, we're not just caring, as I mentioned earlier this week, we're not just caring for somebody, but we're caring about somebody, which is a great
Mhm.
ethical burden because
Mhm.
um, Dr. Christian is a medical doctor, and his literal job, what he was trained to do, was to care for patients. That's the language you use, right? You say, I'm caring
Mhm.
for my patient. But that doesn't mean that you have to care about your patient.
Mhm.
That's something different. To care about your patient is an ethical statement because
Mhm.
now you got to push yourself to do this. When my sister was sick, Dr. Christian was not her doctor, but he intervened with the doctors when they were seeming when they were sluggish. And so now he was not in the position of caring for, but he was in the position of caring about. And
Mhm.
so the challenge when we have such a humongous number, Dr. Sneed, of women, what do you think would be a good avenue? Like I said earlier, I don't know if you heard me say what I said earlier. We're not trying to answer any questions this week. We're
Mhm.
trying to raise questions of which we should
Mhm.
struggle with
Mhm.
the rest of the year.
Mhm.
But what do you think, or what would come on the top of your head? What, in terms of empathy and care, that is focused on the individual rather than the population?
Mhm.
How public health is about limited resources, right?
Mhm.
What would you suggest um, those very intimate and personal responses that you represented? Because
Mhm.
whether you agree or disagree, they spoke from the heart. Those women
Mhm.
spoke from the heart.
Mhm.
What would you suggest is a way that we could increase the caring about for
Mhm.
for women with lupus? How can we put a more personal touch? How do
Mhm.
we create visibility to this
Mhm.
invisible group? Because by
Mhm.
the way, I was messaging and people were messaging me in the chat, and you know what some people said? I've heard of lupus.
Mhm.
My baby mama's great sister, sister
Mhm.
cousin has lupus. I heard that. I really
Mhm.
don't know what it is. So you were really
Mhm.
brave to put it out there. So the question is, how do we bring this how do we make this more popular as a conversation so
Mhm.
that um so that people, particularly women, who are going through this experience with lupus, that they will get the kind of personalized, like the IEP that Dr. Christian talked about, the individual educational plan, this kind of individual physician plan, that you can get this kind of personalized, empathetic, empathic care that they deserve. What would you suggest? What's on your mind?
Well, a lot of the women, I'm interested when you're talking about sort of motivation to participate, and you're talking about this sort of utilitarian thing, the idea that you're sort of participating in something that's not going to have a direct benefit for you personally, but it's going to serve the greater good. That's how we talk about this stuff. But interestingly, the women who participated in our focus group said that wasn't really what motivated them. We're talking about a disease that runs in families. So they're like, me participating could mean something different for my children and for my grandchildren. It's something very personal to them because they've seen it go through their families. And I sort of think about, people may not be aware, lupus is not as common as a lot of other health conditions that we see in Black communities. But, I think that there's more visibility. There are more faces to the disease than there used to be. You've seen, more Black celebrities become public about having it. I mentioned Toni Braxton as one example. Nick Cannon has lupus. As there's more faces to what the disease actually looks like and there's more awareness of it, that does make it personal. People talked about wanting to help their families and also wanting to help other Black people. For those people who did say they wanted to participate in research, they wanted to help people who looked like them. And so this idea that it's personal for the women in general. And so I think, as we're talking about raising awareness, like it's really important for people to recognize you do probably have somebody in your family who has lupus. They may not talk to you about it. It may not be, cause as much mortality as other types of things. But it is important for you to be aware of this because it does affect people that look like you. So, it's not about something that sort of is just being of benefits to white women, even though they're the ones participating in the research. The more you participate, the more you are helping people who actually have a connection to you, whether they look like you or whether they're related to you. And so the women told us that, that they were motivated to participate in many instances because of that. And also I think that they talked about the fact, so I mentioned that, my colleagues who do this research with me are clinicians that see women every day in the clinic. And they'll tell you, this doctor saved my life. I trust her. I came to her when I didn't have anybody else. I flew all the way to Chicago from California because people told me this woman saves Black women's lives. And so it was very personal to them to be able to participate in something with that doctor who they trusted and saved their life. So I think sharing those stories and sort of putting a face on the fact that this is personal, that this matters to you personally. It's not just about this sort of greater good that you can't see, but it's something that's directly impacting you. I think is sort of a way to shed light on it as something that is, something that's more personal and people can have empathy and actually caring about the person themselves and not something that's just kind of nebulous.
That's beautifully stated. As a matter of fact, I see Dr. McDuffie and Dr. Christian nodding their heads so they could chime in if they feel so such a desire. I want to read something that was written in the chat by Barbara Council, and she said, "Well, my chat is disabled, but me and my family of 3 adult kids, 2 daughters and a son, and 3 grandsons have been doing research since 2005, both clinical and non-clinical. I would like to be considered as an advocate for others. My other family members may also consider it too." Now, what she said, I thought as I was reading what she just said, and you at the same time saying something that it seems to kind of dispossess us of the idea that you kind of get a kind of aroma of 1 or 2 of the persons. They're like, "Oh, here we go again. You want us to trust you, huh?" Wait. So, like, wait a minute. First of all, we don't even think you're honest with us. We don't. So we get that flare. But here's a person who's saying that we're already doing this. We're advocate, because I think what she is saying here is that not for any utilitarian basis, but I like it better how you framed it. I'm not doing it for utilitarian reason, although it does consequentially come out to be that. But I am doing it because in so doing, I could help somebody other than myself, which is what empathy is about. It's about being other regarding. And so it's beautiful. So so then I think somewhere in our conversation, we need to reshape our definition of what a social contract should look like. So that this social contract has, in what we're discussing, is not a selfish one, but it is something germane to language of visibility of the invisible, and that they continuously constructing their visibility. I mentioned this several times before, I continue to mention it. I am so, the thing that I miss most about Tom Joyner, and you have Steve Harvey, and I think what's the guy name? The other funny guy, who's doing morning radio. I'm not sure if they're doing it or not doing it, but this is a great opportunity. Not Steve Harvey, Tom Joyner. Tom Joyner, who came out of Tuskegee University, is take your family to doctor, take your loved one to doctor day. I don't think we have any numbers about, but I think anecdotally that did a whole lot of good, because it played in the back of my mind, the same sister who I was just discussing, it played in the back of my mind each time she had cancer, and I went to every single one of her Jonathan took my phone. I went to each and every one of her doctor visits, her oncological visits, because we have this device. So now, if you can't come all the way to Union City, I think that's what it's called, or Union Springs, or wherever it is that Dr. McDuffie comes from, to take your family member, but you can go with this device and query the doctor. Because I think one of the most powerful things of what you just said, and we see it all throughout the work that we're doing, particularly during the pandemic, is trustworthiness preceding trust. Before a person, a client could make themselves vulnerable, trust is about vulnerability, make themselves or himself or herself vulnerable to any clinician, that clinician has to show himself or herself trustworthy, or themselves trustworthy, but you don't know that going in. A person could be trustworthy, but we don't know that going in, because you're not, this is a doctor that you went to the emergency room, and this is a doctor they gave you, right? But at the same time, we can foster those relationships. So my point is, I think in the work that we do, in the clinical trials work that we do, as well as all the research that we do, that there should be some portion of the conversation that says to patients that not when you're about to die, as one of them said, you're killing me, but that fosters conversation about going to the doctor on such a regular basis, such that the trustworthiness is understood and developed. Dr. Christian and I come from the Caribbean. Black men in the Caribbean, they're not in favor of is it called a proctological exam? Did I say it right? For the proctological,
the digital rectal exam.
Yeah, okay. Digital rectal, they're not interested because they see that as being gay. And I said, but you realize that your health depends upon this, your life depends upon it, early detection depends upon this. And they said, no, I'm not a body boy. I'm not that. So they would rather put their lives at stake. So my point is, in everything in my little diatribe, is that I think we need to, in part of our early intervention, our access and our conversation and our research, that we need to put in there some conversation that will increase trustworthiness, increase our access to the trustworthiness of the doctors. The doctors may be fully trustworthy, but we've heard all these anecdotes that, as the stuff that you read, some of the stuff that you read about, so the so-called Tuskegee experiment is not applicable here. But there's still anecdotally or a sidewalk conversation. Oh, I'm doing that. You hear what happened in Tuskegee? As Dr. Brendel showed, I think what Dr. Brendel showed yesterday, the SNL, the Saturday Night Live. Wait a minute, was that Brendel or was that Dr. McDuffie? Who was it? Okay, it was Dr. Brendel. The SNL conversation, things about where they talk about the Tuskegee experiment. I've been doing that. You remember Tuskegee? So they could foster this false narrative that people are into. And they do it jokingly, not realizing that it actually intensifies the distrust.
Absolutely.
We have additional burdens. So that's what I wanted to, that's the part I wanted to mention and bring. I think that was a powerful and wonderful presentation. Dr. Christian, you have a question or a statement?
Question statement slash Dr. Sneed, excellent research. I am not surprised, but really amazed how forthcoming a lot of these women were in their responses. I always say that you cannot pay for one particular thing, and that's honest feedback. And in the measures that we're seeing, those feedbacks were honest. Now, I imagine from this research that you have the opportunity to now help craft appropriate questions and/or education that will apply to increase in participation of African American, Black and Brown individuals in various research, because when we don't participate, the data becomes extremely skewed. But a lot of times we see ourselves as African American, as Brown and Black individuals, as extra to mainstream America. And a lot of times we use items of the past, and you know, our history is replete with enough examples of mistreatment and maltreatment. And I have multiple stories. I swear one day I'll write a book on stuff you just can't make up, would be the title. There's so many of it. So I realized that there's a need for an incredible amount of re-education and the way we think about things. And once upon a time, we had public service announcements where we put those things out there. You know, the Surgeon General says thus and thus. We don't really see that anymore because the commercial space has become so pricey that those messages are disappearing from mainstream media and exposures, et cetera, et cetera. In terms of increase in that participation, what do you see the role of those types of things are when it comes to increase in awareness, increase in participation within the Black and Brown communities, with the also the caveat of the celebrity influencers? You know, when Jackie Joyner Kersee and Flo Jo, you know, started talking about asthma and health and eating right, you know, I bought the poster and put them up, and I was ready to eat and, you know, eat right, et cetera, et cetera. So I think those things have a role, but with the, in light of the research that you've garnered, what do you see as a way forward? And I'll mute myself for your response.
Yeah, great question. So this research was the first step, sort of gathering this information, but it was not the last step. So our teams have actually done a lot of things related to that. So one of the things that we did was we developed some modules called Lupus Conversations that talk about a lot of these issues that participants raise with us. And so what we've been doing is actually educating identified leaders in the communities where we work on lupus, on some of the issues that people raised, educating people on clinical trials and how they work and why people may or may not be excluded, such that these leaders get this information and then they can pass it along to people in their communities as well. And so we've really tried to take the suggestions. We've tried to make the videos to be sure that, you know, any information that we're giving out is in plain language. And we've also tried to distribute this information beyond just the clinical community that we are in, but also throughout, you know, the rest of the lupus community as well. So doing partnerships with the Lupus Foundation of America, partnerships with other research institutes that do work related to lupus. So Dr. Hodge mentioned the folks at University of Alabama. So, you know, we've given them access to the resources that we've created as well, so they can do the same things in their communities. They can identify leaders in the communities that are respected, that are trusted, that people turn to for information, health or otherwise, and actually pass that information along within those communities. So it was never our goal just to sort of be able to say, hey, these are the problems, but we wanted to actually do something to address some of those problems. And so, we're continuing to do that. We've gotten funding from the Office of Minority Health specifically to partner with a lot of these research organizations that do lupus work, and especially are trying to address disparities in lupus so that we can spread this messaging. So oftentimes we see the lack of participation is just about a fact of, things being ambiguous and people not understanding what's going on, and doctors not doing a good job of communicating. If people don't understand what's going on, you play a role in that, and acknowledging that you play a role. It's sort of being very communicative about what's going on. So I think it's a lot of sort of taking what people have told us and just literally doing the things that they tell us to do. Like they know their communities better than we know them, and just listening goes a long way. And so that's what we've really been doing, and those are sort of the steps that we've been taking to address this.
Dr. Sneed, there's as we bring this session to a close, and thank you so much for sticking with us. We after that was started, it got really scary. We thought that we would not be able to pull it off, but we got it. We got on, and we got it going. And we thank you for your patience. We thank Dr. Cross for his patience, and the brother and sister Green and Dr. Tricia for your patience, so that we could make this happen. I'm going to ask you one question to just give us close it out. I want to mention, I will be remiss if I don't mention three things. Three persons. That is Pamela Foster at University of Alabama, University of Alabama, Tuscaloosa, who brought me into this group, into this conversation, because had she not done so, lupus would not have been a part of this conversation today. And we have to get the word out in every possible way. So we got to get onto as many people's radars we can. Second, one of the persons I met in that forum is Dr. Ramsey Goldman, and she is at Northwestern University, and she's one of her colleagues, and that's amazing. As a matter of fact, she wants to hear this because she's travel right now. Should have been your interlocutors for today. So we're thankful, and again, thank you for such a brilliantly, carefully crafted, as Dr. Christian put it, such a meticulous presentation. And finally, the Office of Minority Health is where the National Center for Bioethics and Research in Healthcare, with the lead person there was Miss Jo Valentine, and now Norman Hayes, and they're the ones, and Leander Mena, and Leandris as well. They're the ones who made it possible, continue to make it possible for us to serve and put on this public health ethics intensive and commemoration. So we want to thank the Office of Minority Health, because they too support us. Finally, so the question I have for you as we go out the door, is to quote again, like I said, that what Dr. Lachlan Furrow often puts in our table, and that is 10 years from now, because I want you to help me to understand what I need to be doing from this chair for the National Center in 2024. So what can I do to be helpful in the work that you're doing, particularly in lupus? And I just looking at what I read, you're doing stuff way beyond lupus, God bless you. But number one, what can I do to be helpful? But and secondarily, in 10 years from now, what do you envision 10 years from now, so that we don't have to have this particular conversation? What can we do so that 20 years from now we say, you remember when that was a problem, but that was the case, but we're over it. So number one, what can we do at the National Center? And number two, and by the way, and by that I also mean we'd be glad for you to help us do it, to commit to it. And number two, 10 years from now, what do you see? And what would it take for us to get there? You don't have to give any answers, but just let us know what is there so that we can work towards that end.
Okay, yeah. I think in terms of things that can be done now, I think there aren't enough conversations about some of these ethical issues. So the women in our research raised a lot of really important ethical issues. And I think it's really worthwhile to have, an ethicist and a center that's dedicated to bioethics, that they can actually talk to people who have a lot of more keen understanding about some of these ethical issues and kind of how to think about them. So I think more conversation and more transparency about what goes into the ethical decisions that we make with respect to clinical care and research, to actually be able to talk to experts directly the way we are here today, I think would be really beneficial. Our research participants, our clinical participants are bright. They know what's going on. They've done a lot of research on their care. They know more about lupus oftentimes than many of the clinicians out there. And so they want to be able to have these conversations with experts and aren't necessarily able to have that direct access. So that'd be something that I would really want to see, that I think could be really beneficial. I also think that when we're talking about the disparities in lupus, and particularly the racial and ethnic disparities in lupus, there are a lot of social factors that I didn't really go into that sort of impact the ways in which people get care and in terms of the kinds of outcomes that they have. And so I would be remiss in saying, if I didn't mention the fact that those social factors are just as important as whether or not there's a new pill for lupus. So 10 years from now, I would like to see us be able to say that we've closed the gap on some of those social factors, things like the economic instability that Black women with lupus face, because, they may not have the same types of job opportunities and careers that white women have, the types of stressors that make it difficult to manage your health, whether you have lupus or not, seeing reductions in those. That's what I would love to see. And that applies across health conditions. That's not just a lupus thing. All of the different health conditions that you all are talking about, there's social factors that play a role in, how diseases progress. And so I would like for us to have serious conversations about how we can actually reduce some of those social inequities. That would be what I want.
Well, that's what we do. Thank you. That's what we are doing here, and the people on the screen and all these people this week are helping us to get that done. So thank you so much. And you have put so much on my table. What I said at the end of last year's PhD, and now I can get to work and do this is what I do. And this is why I'm here, to reach out to the least, the lost, and the left out, those who find themselves with their back against the wall. And I love how you just put it, that there is a bioethics center here that is serving as an advocate for those people who lack have lack access, but to kind of deal with the social determinants, as you just mentioned, the political determinants, as Dawes mentioned, that lead to a moral determinants of health. Those two factors and others, they get to the moral. So we have to do a better job. And when I said we, I'm talking about we at the National Center. We have to do our best to bring people together to have these conversations. I say this, if we could help one 13-year-old girl in Kenya, or one 13-year-old girl in Ukraine, or in Palestine, or in Israel, such that they live another day, or to get another meal, then we are grateful.